All right, welcome back, everybody. Thank you again for joining us for day one of our Hep B United and TB Elimination Alliance mini summit. This workshop is called Know What is Covered, and I will be introducing the speakers and myself in just a moment, and then we will hear from the presenters back to back. We'll go into a moderator-led Q&A and then also take questions from the audience. So in this session, we're going to be hearing more about current hepatitis B screening guidelines and insurance coverage, the challenges there are with that, and some related advocacy efforts. We'll also hear more about guidelines and insurance coverage for both adult and childhood hepatitis B vaccination. And importantly, we'll hear a community perspective around screening, hepatitis B screening, and ensuring policies that increase access to screening and vaccination for all. Just as a reminder, you can submit questions for the panelists using the chat box at any time during the session. Forgot to introduce myself. I'm Rhea Racho, Program Director for Advocacy and Engagement at the Hepatitis B Foundation, and it's really good to see so many of you joining us today. We have a great group of presenters for this session who will be joining or who will be presenting and then doing the live Q&A afterwards. First up, we'll be hearing from Michaela Jackson, Program Director of Prevention Policy for the Hepatitis B Foundation. She'll be followed by Dr. Kelly Moore, President and CEO of Immunize.org. Then we have Andrew Pham and Winnie Gong, co-directors of operations for the Asian Pacific Health Foundation, and Alan Doan, who's a program director for the Asian Pacific Health Foundation. So with that, I will turn it over to our first presenter, Michaela.
Hi everyone, my name is Michaela Jackson and I'm the Program Director of Prevention Policy for the Hepatitis B Foundation. Today I'm going to be talking a little bit about hepatitis B screening, the current challenges in this space, what is currently covered by insurance, and what could potentially be covered by insurance in the future underneath the new recommendation. So to kind of lay the landscape and put things in a bit of perspective, two major challenges to screening right now are that there's a lack of identified risk factors or just a missing risk factor for a lot of individuals, and that a lot of infections are undiagnosed. So with 66% of acute hepatitis B cases having a missing or no identified risk factor at all, it makes it incredibly difficult for a provider to go ahead and figure out who needs to be tested and who doesn't. It also makes it really difficult for an individual themselves to go ahead and know that they should be asking the provider to test them. And with up to 75% of all chronic hepatitis B infections in the US going undiagnosed, a lot of individuals don't know that they're even going to need to go see a doctor because they might be feeling fine as this is primarily asymptomatic virus. They have no idea that they were even exposed to it potentially, and it makes it all the more difficult to go ahead and know exactly what your next steps should be. So some additional challenges that I wanted to highlight in this space, which you guys are probably already familiar with, but I think are really important to mention, is that it's very clear that risk-based screening just simply isn't working. We know that hepatitis B has risen by 11% in recent years on a national level. We know that certain states that have been hit very hard by the opioid epidemic have seen increases of acute hepatitis B up to 500%. And we simply know that overall, we're seeing rises. And with hepatitis B vaccination and hepatitis B screening availability, we know that we shouldn't be seeing any increases in hepatitis B cases, and yet we are. So I also think it's important to note that we've had these risk-based recommendations from the CDC for over 10 years now, and risk-based screening has been recommended by the United States Preventive Services Task Force for over 6 years now. So with two very prominent organizations that a lot of groups look up to when making their own recommendations have made these, risk-based guidelines, we should see it working, and we're simply not. The second one is that there's a lot of stigma in these communities. There's self-stigma, there's stigma from their families and from the community as a whole. A lot of groups who are heavily impacted by hepatitis B do not feel comfortable talking about it. They might feel like they have done something wrong to deserve this virus and to deserve living with such a disease. They might feel like other people will judge them. They might judge themselves. And all of that really impacts a person's access to care because, one, if you don't get tested, you don't know your status, and you don't have to feel these things. You don't have to worry about telling your family. You don't have to worry about telling your friends. Another is that we're talking a lot about marginalized communities. They already are disenfranchised and might be facing challenges in accessing the healthcare system in the United States. And so when we're adding stigma and forcing these individuals and placing the burden upon them to talk to their providers about things they don't feel comfortable about, whether that's their risk factors for hepatitis B, whether that is what they've gone through in the past and they've exposed them to hepatitis B, it puts a lot of burden on the individual to access care that they just might not already be there. Additionally, there's a lot of level of low awareness amongst patients and providers. We're also placing a certain burden upon providers by making this a risk-based recommendation right now. Providers have to, one, go through a checklist of all of the risk factors that a person could potentially have for hepatitis B, and then they have to decide which tests they need to order. And if we're only talking about primary care settings, hepatitis B is not their specialty. There are several tests out there for hepatitis B, and they make it really confusing and challenging for a provider who's only has a limited amount of time with the individual and has to make these decisions quite quickly. Additionally, again, patients simply might feel fine. They don't know that they're at risk for hepatitis B because hepatitis B is not widely talked about in the United States. They don't even know what it is, potentially. And how are they going to know to talk to their provider about something they don't even know exists? So right now, the CDC is moving towards a recommendation for universal screening for hepatitis B. I do want to point out that the current risk-based recommendations for Hep B from the CDC and from the United States Preventive Services Task Force only actually recommend hepatitis B surface antigen testing. So when we're talking about universal screening, we're talking about a one-time hepatitis B test for all adults 18 and over. And this is going to be the 3 core hepatitis B tests. So hepatitis B surface antigen, hepatitis B surface antibody, hepatitis B core antibody. And all of these tests together are really what's needed in order to paint a full comprehensive picture of somebody's hepatitis B history, whether they've been vaccinated, whether they've been exposed in the past, or whether they currently have the virus. The second change that we're going to see is going to be a little bit in line with current recommendations where they recommend periodic testing for all individuals with ongoing risks, so people who choose not to get vaccinated for hepatitis B, although we hope they don't. But we also added some new risk factors or new risk-based groups to the recommendation as well. So if you have a current or history of a sexually transmitted infection, those individuals who might be currently or were formerly incarcerated, and people who are living with hepatitis C are now added to the list. And additionally, we're going to broaden that, those risk factors for hepatitis B universal screening, and add anybody who requests hepatitis B tests can receive one underneath these new recommendations. So what does that mean for insurance coverage? First, we're going to take a look at what the current insurance coverage is and what it could potentially be in the future. So it's important to just kind of start out and say that underneath the Affordable Care Act, preventative services like hepatitis B screening are covered, but only to a certain extent. In general, pregnant individuals and people with high risk factors for hepatitis B or at high risk for hepatitis B have current insurance coverage. But again, this varies based upon what your insurance coverage is. So for Medicare, you can only access it in primary care settings, and it's only covered for high/intermediate risk individuals. So if your risk is low, chances are you're probably not covered for it, or what they deem your risk to be low, you're probably not covered for it. Underneath Medicaid, this varies by state, unfortunately. So if you're in a state where there's Medicaid expansion, you might have access to more preventative services and might be covered for you than in a state where it's not. And for private insurance carriers, only individuals who are recommended to receive hepatitis B testing are the ones who will be covered. So that's if you really fall into any of those high risk categories, most likely as defined by the USPSTF. And what we could potentially shift to underneath the universal insurance coverage is an unknown. Right now, Medicare aligns pretty closely with USPSTF for what they determine their high and intermediate risk factors to be. And private insurance could potentially be covered, and we'll talk about that in just a second. But we do know those core risk factors who have always been covered underneath this recommendation, the current recommendation, pregnant and high risk will be covered. But right here, this group where anybody who can be tested will and wants to be tested and asks their provider to be tested, we don't really have an idea if they will fully be covered. And here's why. When CDC's updated hepatitis B screening recommendations come out, they will not be aligned with USPSTF's recommendation. USPSTF only updates or actually reviews their evidence around every 5 years for all of their recommendations. They last looked at hepatitis B in 2020. We're anticipating the CDC to come out with this recommendation in 2023 sometime, which means there's a potential gap in coverage until at least 2025 when they might look at it again. That's a really big deal for this community because now we're not going to see an alignment, and a lot of commercial and private insurance plans align with USPSTF guidelines, which gives them the potential to reject anybody who technically falls underneath the new CDC guidelines for coverage. And also it makes it a little bit difficult when we're trying to align with universal hepatitis B vaccination recommendation. And this is because some individuals might need to be tested. Well, the recommendation is that you would test first and then vaccinate an individual in that order. But if there's not really an incentive right now, providers don't think you're going to be covered for that screening test. We're just going to be vaccinating a lot of individuals who might potentially already be impacted by hepatitis B and might be living with it. So it creates a little bit of a challenge about how we're going to reconcile these two new recommendations. So we've been working on a little bit of advocacy here at the Hepatitis B Foundation and trying to get the USPSTF to take an earlier look and reconsider their rating of only at-risk individuals being covered for hepatitis B insurance coverage. And we currently submitted a letter to USPSTF, which was a community sign-on letter, asking them, providing new evidence to look at their rating earlier than 2025. And so we will keep you updated when we hear back from them. They do review all of the new evidence, and based upon that, they make a recommendation. I do think it's important to note that there's the potential that USPSTF does not actually align with the CDC's recommendation, and this is simply because they don't have to. They're an independent body, and they make their own decisions, but it's incredibly important that they do to make it life easier for the patients, life easier for providers, and life easier for the insurance companies who are going to need to cover these insurance costs and these preventative services. And so we might be calling on you for advocacy as we move forward and try to convince the USPSTF of the urgency of this recommendation and to reconsider what they've currently looked at. And finally, I just wanted to leave you with my contact information. Thank you all for listening. I look forward to your questions.
Good afternoon. It's a pleasure to be with all of you. My name is Dr. Kelly Moore, and I'm the president and CEO of immunize.org. And I'll take the next few minutes to talk about hepatitis B vaccination and understanding what is covered under insurance and who experiences out-of-pocket expenses associated with hepatitis B vaccination, as well as how that's changing in the year ahead. First, we'll start by talking about hepatitis B vaccine and who it's recommended for. First and foremost, it's recommended for children beginning at birth through 18 years of age. So most children receive it in the first few months of life, and they only need one series for a lifetime. Others who might have missed those birth doses can receive their vaccinations anytime in the next 18 years. As of April 1st of this year, CDC published its recommendations that all adults under the age of 60 should also receive a complete hepatitis B series if they have no or unknown history of hepatitis B vaccination. There's also a recommendation for a complete hepatitis B vaccine series for all adults at increased risk of hepatitis B infection or severe disease who have a no or unknown history of complete Hep B series vaccination beginning at 60 and over. So everyone under 60 should have completed a hepatitis B vaccination series unless they're chronically infected or immune and have received the vaccine before. And people over the age 60 and over should also receive the Hep B series if they have any risk factor at all. There is also the permission that anyone 60 and over may be vaccinated if they or their healthcare provider believe that that is important and would like to vaccinate them, regardless of any known risk factor. Unfortunately, out-of-pocket costs reduce the likelihood of vaccination, so it's important to know what is covered and for whom. So in this talk, I'll quickly review coverage and risk of out-of-pocket costs today for children, adults, and older adults, as well as important changes in out-of-pocket costs due to the Inflation Reduction Act of 2022. So just to give you a background, coverage for vaccines ages 0 through 18 years is excellent in the United States, and there is affordable access for all children and teens in these groups. Either they're covered through commercial insurance, which is compliant with the Affordable Care Act, meaning that there's first dollar coverage for all ACIP recommended vaccines with no deductible or copay. These vaccines are added to commercial insurance 1 year after being added to the published CDC schedule, and this includes both routine and permissive or shared clinical decision-making recommended vaccines. For all children who aren't covered through commercial insurance, they have access to the Vaccines for Children, or VFC program, in participating facilities. These facilities take care of all uninsured children, all Medicaid eligible children, all American, Indian, and Alaskan Natives, as well as the underinsured, meaning children who may have commercial insurance, but the vaccine is not covered, perhaps an ACA exempt plan. These children are covered in designated federally qualified health centers or rural health centers. VFC vaccines are federally funded, their administration fee is capped, and the administration fee is waived if it's not affordable for the family. Coverage for vaccines for people ages 19 through 64, as of today, is complicated. Commercial insurance that's ACA compliant, just like for children, includes first dollar coverage for recommended vaccines with no deductible or copay. But ACA exempt commercial insurance, short-term emergency insurance, or grandfathered plans vary in their coverage, and there may be copays or costs associated with vaccines. Medicaid has two categories of eligible beneficiaries. The traditionally eligible Medicaid beneficiaries in states have coverage and cost sharing that differs state by state because this is a state federal program. When the federal government offered the opportunity for states to expand Medicaid to new groups, this was done by 39 states, and a condition of that was that vaccines are covered for expansion-eligible Medicaid recipients with no out-of-pocket expense. And then finally, the uninsured adults. These adults have access to vaccines either through self-pay or through federal 317 funds that are available to states for vaccines for the uninsured or underinsured, or those vaccines may be used in outbreak response. There's limited availability of these funds, and the funds and their use varies by state. So we can't guarantee that hepatitis B vaccine would be accessible to all without health insurance coverage. That's very much variable and will depend on the state's needs and priorities. Coverage for vaccines for people ages 65 and over today is also complicated. Medicare Part B covers influenza, pneumococcal vaccine, and hepatitis B vaccine for people at high risk of hepatitis B, and also covers vaccines when they're used as treatment or post-exposure prophylaxis. Part B coverage has no out-of-pocket expense for the recipient. Medicare Part D, on the other hand, covers all other recommended vaccines, including hepatitis B vaccine for people not at high risk. And these benefits can vary widely, even for the same patient over the course of a plan year as they hit the donut hole for expenses. Uninsured people who are ineligible for Medicare, perhaps because of their immigration status, may have access to federal 317 funded vaccines, but again, this is limited and it varies by state. Now to cover the big change coming in the coverage for vaccines for people ages 19 through 64 after October of 2023 as a result of the new Inflation Reduction Law passed a few weeks ago. This highlighted section is where the change is occurring, and that's in Medicaid. The new Inflation Reduction Law combines traditional and expansion Medicaid eligible individuals with the same coverage. All of them, both traditional and expansion, will now have no out-of-pocket expense associated with routinely recommended ACIP recommended vaccines. There's also no out-of-pocket expense for young adults aged 19 and over who are ineligible for VFC because of their age, but who are still on state child health insurance plans or SCHIP plans. So this is a critically important new barrier that's being removed for the people who have traditional Medicaid eligibility and SCHIP eligibility. The other really big change coming next year actually comes on January 1 of 2023, and that is a change in coverage under Medicare Part D. Beginning January 1st, all recommended vaccines that are covered under Medicare Part D will incur no out-of-pocket expense to the recipient, just like Medicare Part B plans. So this is an important expansion and will affect recipients of hepatitis B vaccine who are 65 and over who want to be vaccinated but have no identified high-risk factor. So the key points about the coverage of Hep B vaccines: out-of-pocket expense barriers will vanish for many in 2023. This includes Medicare eligible adults who will be covered with no out-of-pocket expense beginning in January, and Medicaid eligible or SCHIP eligible adults who will be covered with no out-of-pocket expense beginning in October of 2023. The reason for the delay is that states will have time to write regulations to implement this new law in each of the states, and we'll be watching carefully to make sure that the implementation rules established by the states make it very clear that these Medicaid eligible recipients will have access to hepatitis B vaccines with no out-of-pocket expense. Now, some adults with ACA compliant insurance plans may already be eligible with no out-of-pocket expense. The ACA compliant plans do have more time to cover these people if they need it, but many insurance plans go ahead and begin covering a new recommended vaccine like hepatitis B without delay. Short-term and grandfathered ACA exempt plans still are going to vary in policy. Now, our focus at immunize.org is on twofold with this new change in policy. The first is focusing on the opportunity, or as you might say, carpe diem and vaxxum. We want to raise awareness of the new universal hepatitis B vaccination recommendations for all adults under the age of 60 and the option for vaccination of all adults over 60 and over. We want to raise awareness of the new affordable access coming for most adults next year and support establishment of routine adult Hep B vaccination clinical practices. This includes helping clinics understand about the importance of hepatitis B screening for disease, but also the ability to vaccinate now and screen later if screening is not affordable to the vaccine recipient or is refused at this time. Vaccination will not mess up their ability to screen the person for disease later if they need to. And we also focus on the implementation of hepatitis B vaccination standing orders and tips on how to improve the routine workflows for implementation of hepatitis B vaccination for adults. Our second focus is on advocacy for the vulnerable adults who are left behind. This health equity focus is really critical to us because now uninsured adults are the last population without guaranteed affordable access to vaccination. So we are strongly supportive of federal funding and policy to implement a future Vaccines for Adults program to close this final gap for good. I hope that this has been helpful to you and just want you to know that if you want to keep following up on what changes in immunization policy and resources available for implementing hepatitis B vaccination, you can subscribe to our weekly free e-newsletter, IZ Express, at the link provided, and that will make sure that you get in your email inbox, along with 55,000 other recipients, updates about new changes in CDC policy and resources that are there to help you implement vaccination in your practice. You can also follow us on social media for educational updates at immunize.org without the dot. Thank you, and I look forward to taking your questions.
Hello, I'm Andrew Pham,
Hello, I'm Winnie Gong.
and we're co-directors of operations for the Asian Pacific Health Foundation. Today, we'll be talking about how we've been using screenings, education, and technology to increase awareness on the hepatitis B virus. So the Asian Pacific Health Foundation is a nonprofit organization based out of San Diego. We do screening and education outreaches for underserved communities, and we focus on silent diseases such as viral hepatitis, metabolic syndrome, and tuberculosis. And silent diseases are diseases that go undetected until real damage has been done to our bodies, making screening and education efforts very important.
Alrighty, so here's a brief summary of the flow at our outreach events. Patients can start off completing our registration form and provide consent to receive any combination of screenings offered for that day, whether that be Hep B or metabolic syndrome. After they've completed their screenings, patients will be able to learn more about the diseases they've been screened for from on-site medical professionals and be connected to local healthcare providers for continued support. So since 2019, we've been able to screen over 400 patients across various communities for hepatitis B, with about 30% of patients left without any kind of health insurance. Demographically as well, many of our patients are Asian, one population that has historically been highly impacted by hepatitis B, with particularly low native infant immunization rates. So, as I'm sure many of us are familiar with, hepatitis B serological testing involves the measurement of several virus-specific antigens and antibodies. Different combinations of markers are used to identify different phases of HBV infection and determine, for example, whether a patient has an active infection, like outlined in Profile 3, has immunity to HBV, either as a result of prior infection in Profiles 4 and 5, or of vaccination in Profile 2, or has no immunity and is completely susceptible to infection in Profile 1. So in registration, we ask our patients to self-report whether or not they've been vaccinated for hepatitis B in the past. A majority, almost about 40% of all patients screened reported, yes, we've been vaccinated in the past. Since one of our main focuses at our health outreaches is patient education, we were pretty curious how well correlated a patient's self-reported vaccination status would be to their actual lab results. So the answer from our data seems to be that it depends. So amongst both groups that reported, yes, I've received the vaccine, and no, we haven't received the vaccine, a large majority lacked immunity to the virus. And that in itself is especially concerning to us, right? So not only are many patients unvaccinated to begin with, but if many people believe they've received the vaccine, but actually haven't, that might be indicative of some confusion or miscommunication going on within the community. So this here is another way to visualize our immunization data from the last slide. So from our results, it's pretty clear that patients stand to benefit from increased education efforts, both about hepatitis B as a disease and from the importance of vaccination to gain immunity. So profile 1 is the most common. It indicates the lack of immunity, but the second most common profile that we see, profile 4, indicates immunity due to past or chronic infection. So combined, over about 46% of the population lacks HBV immunity. So for education at our outreaches, patients can take a pre-assessment to gauge any prior knowledge they have on hepatitis B. After receiving education from, let's say, a pharmacist or a physician, patients can then take the same post-assessment to gauge what they've learned. So here we can see exactly how effective education can be in improving awareness on a health topic, where the pre-test score kind of averages at 6 out of 10 correct on the assessment, and that score increases dramatically to an average of about 8 after the education phase and taking the post assessment.
In order to expand upon our education efforts beyond our screening outreaches, we've been developing a new educational model called the Train the Trainer model, where we'll have a trainer educate a group, and anyone, and then people in that group can take over the teaching process and teach it to people within their social circles, so that this way there's an exponential spread of information. And so in order to aid trainers in this process, we've actually been developing something called the Community Education Mapping Application, and it's currently in its alpha release, but it has a few features that I want to go over really quick. So first is the mapping of health awareness. And so this actually is this picture that you see right here. You can search up a zip code and see how many people in that area have been educated on a health topic such as hepatitis B. And there's also an integrated assessment, education, and certification process where trainers can take trainees through this process and get them ready to train others in turn. So it leads back into itself, and it creates a succinct process of teaching and education to teach more and more people. And this leads into the final feature, which is the trainer progress tracking, where trainers can look up how many people they've directly taught and indirectly taught through their learners, in turn teaching other people. So if you're interested in this application, you can use the QR code to try it out, or you can also contact us to hear more about it. And over in the future, we plan on implementing this application in the community in a similar way to what the TB project team has been doing, and I'll leave that to Alan to discuss.
Hello, my name is Alan, and I'm a program manager with the Asian Pacific Health Foundation, here today to talk about implementing DOTS, or the direct outreach through the Train the Trainer strategy, to raise awareness of latent and active tuberculosis in the Vietnamese communities and beyond here in San Diego. So how do we go about that? Well, we start off with a pre-assessment knowledge baseline, just to see what the patient knows immediately about tuberculosis, before moving into our educational activities, of which we use a variety of media and interactive events to engage with the audience. And we finish off with a post-assessment survey, which is the exact same questions as the pre-assessment, only now, with the benefit of our education, we try to see if the patients have learned anything new or have clarified any misconceptions that they had previously. And we incentivize this process, of course, by telling patients they'll be entered into a gift card raffle, just to encourage them to finish the whole thing. One of the things to note is that since we are an educational-based project, oftentimes we have to refer outwards for the actual clinical screenings, because in lieu of clinical funding, we still want to make sure there's that linkage to care present. So what we do, especially here, is with the County of San Diego, we redirect our patients over to their websites. That way, depending on the region of residence that they are at, they can find different health centers that are available for these free screenings, especially if they meet the risk assessment criteria here in San Diego. Just something we wanted to point out are a couple of pictures here of different venues that we participated in over the past year. We've been at health fairs, community fairs, cultural fairs, and in that bottom right-hand corner, we've actually participated in a little high school presentation as well, which I'll talk about afterwards. But I just wanted to touch upon some of the activities that I had mentioned earlier. And again, these are with the intent of engaging the audience, because of course, with any educational project, One of the challenges that we run into is the saliency of information, as well as the attention spans of the patients. And so one of the ways that we try to address that is with these little activities that increase engagement and interactiveness. In particular, we have a little trifold that we use with some Velcro, some stickies, some pictures that patients can interact with so that they can try to piece together the clinical progression of a patient that has tuberculosis. And oftentimes, even if it's incorrect, we'll use it to guide their educational afterwards. Because of that process being collaborative, I find that it helps patients really stick to that information a little bit more, especially once we kind of make the corrections, explain why the steps are arranged as they are. And I find also that having them tactilely interact with the board itself brings them into that process of education a little bit more. And it's especially fun for families and friends that are collaborating with one another in smaller groups. In larger groups, what we found to work as well are these little case study scenarios that we create and mocked up just to demonstrate whatever educational bit of information we're trying to foster conversation on. So in this case, this is a slide that was used in our high school presentation. We presented this little scenario with the intent of having the high school students discuss risk factors for tuberculosis and what might be important for that. And we found that by encouraging them to engage in discussion, to challenge themselves, to have those arguments, disagreements, or sometimes those collaborative agreements together, again, really helps with the saliency of information and helps it really stick with them long after we've finished our education. Something else that we've been working on as well throughout the term is accessibility to information, which has been a struggle, especially over the course of the pandemic, where we were unable to physically attend as many venues. So one of the things that we did in collaboration with our consultants is created some bite-sized videos that patients could consume from the safety of their home and still learn the same content that we would normally present at an outreach. So you can see here, they're organized into different categories, but the idea being they can go to our website, do the pre-test that we normally offer them in person, watch these videos, and then do the post-test as well, getting that same educational experience, but again, from the safety of their home. And this works especially well, especially for patients that might not finish on site, patients that are trying to refer their family to these resources. That's one of the challenges that we were trying to address, again, accessibility. And of course, we're always translating, so we're trying to convert it over to Vietnamese and Spanish as well. The last thing I wanted to touch upon here is just the train the trainer strategy that we've implemented over the past year and the changes that we're making moving forward. One of the things that we originally did, of course, was have our central provider train our trainers, our staff members and volunteers, who would then go out to the community at these outreaches and present that information. But we found that that was especially difficult to do, for one, because of the pandemic, but also because the Asian Pacific Health Foundation is primarily a volunteer-based organization, which means that most of our participants are volunteers that are full-time students, full-time working, and it just makes it difficult to schedule with these events outside of the weekends. So that's something that we wanted to improve on. And additionally, we wanted to utilize those informal connections as well that these trainees might possess after they left our educational events. So going into this term year, one of the things that we're trying to change with our philosophy is to increase the amount of student trainers that we train the trainers to train trainers, in a sense. And this works twofold. The reason why we're focusing on student populations is to increase health literacy and education amongst the youth, but also to utilize those social circles that they have with their family and friends so that we can reach even more communities long after we've held our initial outreach events. That's a small change that we're working on in addition to still attending these events, but it's one that we believe will really benefit our project in the long run. If you have any questions, feel free to email me. The email you can contact me with is here, and my colleagues will answer any questions that you might have. Thank you so much for your
All right, so I just want to invite those panelists that are on to go ahead and join me on video for our Q&A. And I want to thank each of our presenters for going over their topics with us today. Feel free to add. I saw some discussion already in the chat, which is great, and we may bring up those questions to the full group as well. If people would like to continue adding any questions in the chat, we'll be happy to ask our panelists those. But maybe just to start things off, I want to go back to Michaela's presentation. Just as a reminder, she told us about there being a potential gap in the private insurance coverage for hepatitis B screening from the point when CDC is expected to release their updated universal guidelines in 2023 until USPSTF is scheduled to reconsider the topic. So if they don't consider it before then, is there any likelihood that commercial and private insurance plans could or would still adopt CDC's universal screening recommendation?
Yeah, so that's a really good question. The answer, unfortunately, is it's really hard to tell. It's a possibility that they could, but USPSTF is what a lot of commercial and private plans already follow. And so if they don't really have an incentive to go ahead and update, they might simply just choose not to. So that's something that we can look more into, and it might be a really great source of advocacy for us if that issue does arise.
Thank you. And Kelly, in your presentation covering the vaccination guidelines and insurance coverage, I know that on a few of the slides you did talk about Section 317 funding being that potential solution to help cover uninsured adults, but you did point out realistically that there is limited funding and availability, and it varies by state. So I guess I was just wondering if you had any examples of maybe how states have or could go about accessing 317 funds for that purpose.
So the 317 fund, the determination of how 317 funds are used is made by the state public health departments, typically by the immunization program. In my state, so I was a state immunization program director for 14 years. And so the way I would do that is that I had a small bucket of money that was too small to cover all of the needs of uninsured adults. And so I would allocate a fixed quantity of doses that I could purchase with that, because you literally just have this amount of money and you can buy X number of vaccines, and it must cover Hep B and pneumococcal and shingles or tetanus or hepatitis A. Everything has to come out of that same bucket. And so I would sort of figure out, based on the use of the vaccines in health departments, how much I could afford to buy. And so it was kind of this is how much I can afford this year. And when I run out, I run out. But in other states, they may earmark those funds for specific projects. For example, 317 funds were used to support vaccination of incarcerated people in some states, or in a special project to go in and use that sort of funding to support vaccination programs in jail or prison settings where there might be a real need to protect people because of an outbreak, for example. But that's the kind of variation, and it's worth talking to a state immunization program to find out how they use their 317 funds. But in terms of national advocacy, what's really important is to advocate for greater 317 funding overall. It's simply insufficient to meet the needs of our uninsured population, and we need to close that gap in a better way than just filling in little holes here and there.
Okay, yes, that is really helpful, because I know we're trying to look at that from both what can states do, but also if there's not a bigger pot in general for Section 317 funding, it'll be very difficult for each state to then go there and try to allocate funds specifically for adults and for hepatitis B. So I think that's important for us to remember in our overall immunization advocacy strategy. I guess on that note, though, one question, another one for Kelly. I think we've heard from our partners on the ground, so both community organizations and health departments, for ideas on how other ways to maybe access reduced or discounted vaccination for hepatitis B. Is that something that you might be able to speak to?
I'm not aware of additional routes. Now, if they're, in terms of large scale purchases, and Michaela may be aware of other strategies. I mean, right now by the time we get through 2023, we should have pretty reliable access for all adults, with the exception of those who are covered under a commercial ACA exempt plan, because those are quite limited. But uninsured adults are going to be the last gap standing that we need to close. And I don't know details on, for example, manufacturer patient assistance programs, which are sometimes available to access. Usually with vaccines, those programs for patient assistance require either a clinic that has a blanket coverage because they serve only uninsured people, or they may have to have an arrangement worked out where there's dose replacement, where they purchase vaccine and then get doses replaced. But I'm not aware of other discounted ways to get the vaccines. Michaela, you may have other ideas or others.
I don't actually. I think this is a really difficult question. Yeah, we've just heard that some community members and health departments simply just run out of the vaccine, I think, with what they're be able to purchase. And, it's just a massive supply issue because there's not enough demand in order for like other avenues like pharmacists or, other providers to stock it as a backup. And so I agree with what you said, and I think it'll still be a challenge in the future for those populations.
There's there's a lot of talk about a vaccines for adults program that would meet the needs of uninsured adults more completely, the way we do for vaccines for children. But that's probably realistically a few years away. The thing is, we all need to keep talking about it and keep making sure that no one forgets that we have a group that's left behind, and we need to solve that problem in a comprehensive way, because it's a really terrible choice for someone in a state public health department to look at a small bucket of money and say, do I prevent invasive pneumococcal disease, or do I prevent hepatitis B, or do I prevent tetanus? It's just an unfair position to say, what disease do you want to leave people vulnerable to? And they shouldn't be vulnerable just because of their insurance status. And we can fix that, but we need to keep advocating.
Thank you, guys. Andrew and Winnie, thank you guys for providing the background information on your programs, and to Alan as well. I know we have asked you guys to present as well on the Hep B United Coalition call recently, and in some other in front of some other audiences that I think are all really excited to see this creative way that you're reaching the community. Would you be able to talk a little bit more about those next steps in terms of how you might see it scaling to other disease areas or other organizations that might be able to follow this model, or if you have any suggestions on how that could happen for other organizations interested in following this model?
Sorry, you cut out there for a second for a minute for me there. Could you repeat the last part of the question? I heard the preface to it though.
Oh yeah, just if I think people might be interested in hearing maybe a timeline or an idea of when they might be able to take and use the same model that you guys presented today, or if you just have kind of general advice or guidelines for community organizations that would like to do something similar.
Yeah, for us, it's just been a matter of reaching out with community partners, because after COVID, it was we hadn't had contact with a lot of our the community, so it's a matter of reaching out. If other organizations want to expand out to other disease topics with us, we'd be happy to talk about it and stuff like that, and get a more in-depth call, because I think every community is a bit different. That's why one of the things, like let's say what we've been doing with the application we've been developing, is that we want to partner with other organizations to maybe spread hepatitis B knowledge in their own area through the application, because they know what's going on in their community. It's just a matter of knowing connections, reaching out with those people and being on the ground and implementing that. Every community has its own challenges, I think.
Thank you. I did see also just a comment, maybe I'll just kind of bring it up to the group, around the using the acronym dots for the program, just because it may be confusing for patients or people who are familiar with the acronym DOT, meaning directly observed therapy for active TB treatment. So I just wanted to thank one of our attendees for bringing that up, maybe something to consider there.
That's a good point. I don't think we've really encountered that issue, but I guess that is something that we should consider, like changing the name of if it does cause some confusion in the future.
Yeah, or
Yes.
even, I'm sure just pointing it out in materials if it does come up is probably fine. We wouldn't want you to change the whole name.
Yeah, definitely we'll consider making that change in our education efforts. It's unfortunate that Alan couldn't be with us today, but we'll definitely pass that feedback to him, and that was really useful.
Great. And then let's see, I do think there was a question earlier that I think Kelly answered. Kelly and Ed both helped answer in the chat, but I was wondering if there, just so everybody sees it, or if you have anything to add. There was a question around whether the BCG vaccine, since that is given rarely in the USA, does anything change or happen with the Inflation Reduction Act provisions here in the US?
No, that applies only to vaccines that are recommended by the CDC. Typically, the Advisory Committee on Immunization Practices recommends something and CDC adopts that recommendation. And that's what triggers the coverage under the Inflation Reduction Act and the Affordable Care Act as well for commercial insurance. So BCG, because it is not recommended in the United States, there's no US-based recommendation. None of these changes will apply to the use of BCG.
Okay, thank you. So also, there was also a question around, yes, so we can talk a little, I think you covered this as well, but today in the US, since hepatitis B vaccination has been universally recommended for infants, since I think, since the early 90s, we're seeing, you answered this in the chat, we're seeing that most children will complete their vaccine series before kindergarten, but that is also I guess like a checkpoint where that might happen, where whether or not they're vaccinated is checked. So it's kind of a catch-up time, or childhood vaccine catch-up time. So most children are covered. But is there anything else around there that you wanted to add?
Only that, universal infant immunization has been in place in the US since 1991. Birth dose hepatitis B vaccination is now very, very widespread. So not even just infancy, but receiving the first dose within 24 hours of life is now the vast majority of infants receive a birth dose of hepatitis B vaccination, which is critically important to prevent mother-to-child transmission of hepatitis B for an infant who may be born to a mother who has unrecognized active hepatitis B infection. So the first dose alone can help protect them. And that's widespread. So when the implication of that, and because we've had catch-up vaccination of older children, we generally say that, for people under 30, most of them have had hepatitis B vaccination in the past. And when you look at rates of acute infection with hepatitis B in the United States that are reported to CDC, you can see that the groups with the increasing prevalence of acute hepatitis B are actually in their 30s and 40s, which makes sense because they were the group that missed out on both the infant immunization recommendation from 91 as well as the later catch-up recommendations. So that's where the burden of disease is now, which is why our focus is really on those adults in middle age and making sure that they get caught up on vaccination. A couple of quick points to remind people of, in case you're not familiar with some of the tricky parts about vaccines. If someone really can't remember what they've had, then our recommendation in general for vaccination is, if there's no documentation and you can't remember, repeat the vaccination. You give the vaccine, and even if it's a repeat and they didn't really need it, that's okay. So with vaccination, your evidence of your antibodies will decline naturally over time. So if someone was vaccinated 10 years ago, there's a very strong likelihood that they may have responded to the vaccine at the time it was given and actually be protected from disease. But if you did a blood test, they would look negative on the blood test. So that's just something to remember. It's very tricky when it comes to screening for history of vaccination. That's why we always say, if you do need to screen for the take of a vaccine to make sure that the vaccine worked, that's recommended to be done the first month or two after vaccination, when you can be sure of those results. Because the longer you wait, especially if it was several years ago, you may show negative on the test, even though you were successfully vaccinated. So with the general public coming in now as an adult and saying, I need to be vaccinated, I don't know if I ever got the shot, I'm 35 years old, maybe I did, I don't have any records, then the right response for us is go ahead and vaccinate. So that's, we don't want to make this excessively complicated. It won't be harmful in any way to get vaccines if you don't really need them, but it could save their life if they do really need them. And so we want to make sure that people know we in the vaccine world have this issue come up all the time because people lose their records. And we always say, with the exception of, did you get your flu shot this season? Because you can remember what happened a month ago, maybe. We don't take people's word for it. So if they don't have documentation, just say, you know what, just to be safe, we're going to go ahead and start this vaccine series. If you find your records later, great. But if you don't, we want it better be safe. So those are just a few tips that people should keep in mind when they're thinking about this. And they'll be able to bill insurance and get coverage for that for almost everyone. So those are some important things to remember about planning ahead for universal vaccination.
Yeah, thank you. I know that there's a lot of just the even speaking with each other, people who are familiar with these policies, just the fact that things are changing and on different timelines with the guidelines, I think will be very confusing. So maybe one last question I wanted to start with maybe Winnie and Andrew from the community perspective, but in terms of, I think, what you guys see as maybe the biggest challenges or needs for communicating, being able to successfully communicate and reach populations with these changes and with screening and with vaccination. Maybe if you could share or summarize a bit about what you think will be most important and crucial for reaching communities and simplifying this information for them so that they know that when there are out-of-pocket costs versus, which settings they can be covered and all of that. Oh, and I think Ben has a question. I'll let anybody, or if anybody else, Michaela or Kelly, has a response as well. Go ahead.
I think one thing that is important in communicating with the public is that screening is, once we have the recommendation, to make sure that both are offered. But if they say, I can't afford to be screened right now, or I don't want to be, but I'll go ahead and get vaccinated. An important message is you can be vaccinated without being screened. It won't mess up your screening results, but if you still need to be screened at some point. So we're going to ask about this next time, or we're going to ask about this when there's a way to pay for it. But vaccination won't mess up your screening results. We can still tell. But if you have chronic hepatitis B, vaccination is not going to cure you. That is a really important thing to know. Vaccination will protect you if you're vulnerable, but it won't treat the infection. So we still need to screen you and just reassure them that if they have the opportunity to be vaccinated, they shouldn't wait until they can afford to be screened first. They should go ahead and get vaccinated and be reassured that vaccination won't mess up their screening results later, but they still need to be screened, because if they have hepatitis B, the vaccine will not treat it.
I'd like to add that this is a really, really key point, I think, when we're having these two really important universal recommendations that are coming out at different times. The messaging is going to need to be incredibly clear for both the providers and the patients, because if one side's confused, you can almost guarantee the other side's going to be very confused as well when they're having these conversations. So thank you for mentioning that, Kelly. It's going to be critical, and the groups on the ground are definitely working on how we can best message this and together, especially while we're still waiting for the screening guidelines to come out and then for them to actually be covered, which is going to be something completely different as well. If providers don't have an incentive really to go ahead and screen, we still need to make sure people are getting vaccinated as well.
Yeah, one important takeaway from working with the community that I want to mention is that the APHF, we offer like free screenings to our patients, but even with those free screenings, sometimes patients are hesitant to do like hepatitis B screenings because there's certain stigmas in their like cultures revolving around different diseases. And that's why it's important for when we have healthcare providers, we make sure that one of the focuses is educating them that it's not something that has to do with lifestyle, it's about protecting their family. So that's an important takeaway that, it's not just about bringing these resources to the community, but it's about getting them to accept it and explaining to them the need so that they understand the need to be educated on it and be screened on it and get vaccinations.
Yes, definitely. And building off of what Michaela said, the messaging has to be clear because some of the major challenges that we've encountered in our work on the ground is that a large population that we work with are not native English speakers. So the communication barriers kind of exponentially made a little bit more difficult. So any information that we present, whether it's about hepatitis B or any other disease, it has to be simplified down to the simplest terms possible and then also translated across different languages to reach the populations that we'd like to reach. In addition, it is a lot easier for community members to hear this message from people that they trust. So it was a little bit more difficult for us to have our physicians or our pharmacists do the outreach work, but it was far easier for patients to internalize that education after they've heard it from, let's say, a family member or a community leader, perhaps, that they particularly trust. So those components are some of the more, I guess, unspoken things to consider, but definitely, Kelly, it was really nice to hear you talk about how the population that's reaching about 40 to 50 years old now is the population that is particularly susceptible. And that's exactly what we've seen in our outreach data as well. It's not necessarily like the seniors or the really young people that are not vaccinated, but rather those that are 45, 50, 55. So that was really nice to hear. And I agree with that trend completely.
Thank you all so much. I think that's great to see how this discussion has been really helpful to hear from you guys from a community perspective and from what the national advocacy work that Immunize.org and Hepatitis B Foundation are doing. I wanted to thank you guys again for sharing your insights and experience and thank everybody for joining today. This was our last session for day one of the mini summit. Just as a reminder, tomorrow we're starting again at 1:30 p.m. Eastern Time or 10:30 a.m. Pacific. And our theme for tomorrow is reaching all populations. So we're looking forward to getting into more in-depth conversations, talking about the health equity and other ways to integrate hepatitis B and TB work together. If you guys have any questions in the meantime, please feel free to reach out, but we're looking forward to seeing you again tomorrow. Thank you for joining, and thank you again to our presenters from this session and the earlier sessions. See you tomorrow.